One. Please start, sir.
Okay. Yeah. Thanks to Tech Team and thanks for all our doctors for this session of our Nubeka Clinical Conversation 26 with Prostate Cancer Update CME. I am Sagnik on behalf of Bayer Oncology and welcome to Dr. Devapriyo sir and Dr. P.N. Mohapatra sir for this session for their valuable times also. So just for this session of both, I just want to warm welcome to Dr. Devapriya Mondal sir, who is a senior consultant medical oncology from Fortis Hospital, Anandapur, Kolkata, with his rich experience in field of oncology. So giving for warm welcome to sir. Good evening, sir.
She's demanding. Just like him. You know what?
Yeah.
Good evening.
से हम एकदम चुप पर ठीक भी कर दे
Good evening, sir.
हमको जहाँ उठा के जहाँ पर इतने हो गए तो ऐसा बोल सकते हैं तो फिर हमने क्यों भेजेगा
Am I audible, sir?
Good evening, everyone.
Yeah, welcome, sir.
Hope I'm audible. Today we are going
Yes,
to
yes,
discuss about
yes, sir.
the
Yeah.
role of darolutamide in metastatic hormone-sensitive prostate cancer. And in that, we are going to particularly concentrate on its role as a part of doublet. And so we have the senior most medical oncologist of the city, very eminent Dr. P.N. Mohapatra with us. And if we are ready, then we can start with the first session.
Yes, sir. You can start your topic, sir. Here is the first session with topic is this breaking barriers in MHSPC doublet of darolutamide plus ADT leads the way with Aranot. That is the topic, sir. So,
Share my slide.
okay. Should I share or you can share, sir?
Please share.
Okay. Will I share, sir?
Yes.
Okay, okay. Just give a minute, sir. Is it visible, sir? Sir, am I audible, sir?
Yes, yes.
Okay. And I have shared my screen. So can you please confirm, is it visible, sir?
It is visible. Breaking barriers in metastatic hormone-sensitive prostate cancer with doublets, darolutamide plus ADT leads the way with Aranot. We shall discuss more about this trial, Aranot. Next slide. These are our general disclaimer. Aranot currently, darolutamide is approved in 2 indications. And if we look at the shift in standard of care in metastatic hormone-sensitive prostate cancer, it has evolved to combine ADT with androgen receptor inhibitors, abiraterone or docetaxel. Docetaxel was the first non-hormonal agent to be approved after the Charted and the Stampede trials. And thereafter, with Latitude and Stampede, another arm, abiraterone came in. After that, we had enzalutamide, we had apalutamide. And the first trial to show benefit with triplet was Peace 1, showing abiraterone plus ADT with docetaxel. Arasense also showed that darolutamide plus ADT plus docetaxel is a very effective option. Now, in 2024, we had two other studies, ARA-NOTE and ARA-SEC, which has shown that darolutamide plus ADT is a very efficacious and meaningful option. Next slide. So there is unmet therapeutic need of efficacious treatment option, which balances good efficacy, also cuts down significant toxicities. ARASENS is a phase 3 study which showed that ADT now with ARA-NOTE data has the potential to change the treatment paradigm, as now it would be the only ARI which could be used with or without chemotherapy. Next slide. Now, darolutamide plus ADT with docetaxel is a standard of care for MHSPC after ARASENS. Now, ARA-NOTE was designed to evaluate darolutamide plus ADT versus ADT to provide a new treatment option for MHSPC that is without docetaxel. And this is particularly meaningful to us because a lot of patients cannot be considered for docetaxel because of medical fitness issues. Next slide. So, if you look at the trial design, you can see that it is a randomized double-blind placebo-controlled phase 3 study. In it, the patients were metastatic hormone-sensitive prostate cancer and ECOG performance status of 0 to 2. And stratification factors were visceral metastasis and prior local therapy. Darolutamide arm, it was darolutamide plus ADT at a standard dose of 600 milligrams twice daily. And the other arm, it was placebo plus ADT, 2:1 randomization. The primary endpoint was radiologic progression-free survival. The secondary endpoints were waste, time to initiation of subsequent antineoplastic therapy, time to CRTC, and several other options. Now, the open label phase was until final analysis. Open label phase was darolutamide. 100% crossover to open label darolutamide was. Next slide. Now, if we look at the demographic and clinical characteristics at baseline, then we can see that they were more or less well matched. And high volume disease was present in 70% of patients. Visceral metastasis was present in around 10% patients. And prior local therapy was received by 17% patients. So there's a well represented in terms of high risk groups. Next slide. Now, country representation across breakthrough clinical trial for prostate cancer. This was a global trial, the ARA-NOTE trial. It had representation from China, India, Taiwan, Australia, New Zealand. It was a truly global trial with 13.7 and 14.3, that is around 14% patient from India. Next slide. Darolutamide plus ADT significantly reduced risk of radiologic progression or death by 46% versus placebo and ADT. The hazard ratio was 0.54 with a highly significant p-value. And follow-up 25.3 months. The absolute difference in median survival, median radiologic progression-free survival was substantial at not reached versus 25 months only. Next slide. The benefit of darolutamide plus ADT on RPFS was consistent across subgroups, including patients with high and low volume disease. And this was a benefit that was consistent across most subgroups. Next slide. So, with the other endpoints, then the percentage of patients who had received the OS outcome was 23.1. So the OS remains immature. Time to MCRPC also is not reached. So all secondary endpoints are not reached and immature. And we can see that it is much less with a placebo, that is 13.8. Time to MCRPC, time to PSA progression is 16.8. Time to pain progression is 29.9 months. So since OS is immature, patients will be followed up for the secondary endpoint of survival, and all per protocol other analysis will be performed. Next slide. So median time to MCRPC was 13.8 months with placebo, and it was not reached with ADT plus darolutamide. Time to pain progression was also median was 29.9 months with placebo plus ADT, and not reached with darolutamide plus ADT. Next slide. So PSA less than 0.2 nanogram per ml at any time during treatment, that was achieved by more patients, 62.6% with darolutamide plus ADT and 18.5% with ADT plus placebo. And time to PSA progression, if we look at it, it was not reached versus 16.8 months. So absolute PSA control, that was something was also better, much improved, significantly better with darolutamide. Next slide. Now, higher proportion of patients achieve better response and better survival with darolutamide in high volume. And next slide. Subsequent life prolonging anti-cancer therapy, you look at it. Patient with subsequent life prolonging systemic antineoplastic therapy, darolutamide plus ADT 32.5%, and in placebo plus ADT it was 42.5%. Most of them had received chemotherapy docetaxel. Some of them had received switching to another adrenaline receptor targeting agent. Next slide. So any adverse event was almost comparable between darolutamide and placebo, and serious adverse events were also comparable. So this is a very safe drug. Hardly we see in oncology a drug that side effect profile is comparable with placebo. Next slide. So rate of most common adverse events, they are all similar. And if you look at fatigue was actually lower for darolutamide plus placebo versus placebo. So it did not increase any side effect over placebo. Now that is quite a remarkable safety profile. Next slide. So again, rate of ARPIs and their side effects similar across treatment arms. If you look at any CNS side effects, cerebral ischemia, that was almost not seen with darolutamide. Next slide. And darolutamide also confers a positive impact on health-related quality of life. Darolutamide was presented in the ASCO 2025 that darolutamide extended median time to deterioration in PAC-P. The patient reported quality of life measures by 5.1 months versus placebo. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being. Next slide. The darolutamide doublet demonstrated a clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptom domain. So this is a combination darolutamide plus ADT that doesn't only help the patients live longer, it also helps the patients live live longer without progression and also live better. Next slide. You can conclude that darolutamide plus ADT significantly improved radiologic PFS in patients with metastatic hormone-sensitive prostate cancer. Darolutamide showed benefit across all secondary endpoints, and it was associated with deep PSA response regardless of baseline PSA. It is the first and only AR inhibitor which demonstrates clinically meaningful delays in pain progression, overall well-being, including social and family well-being, functional well-being, urinary symptoms, and it has a very safe, favorable safety profile. So darolutamide plus ADT without docetaxel should become an additional standard of care option in metastatic hormone-sensitive prostate cancer. Next slide. So with that, it is a conclusion to my session, and over to the organizers for the next session.
Yes, sir. Yes, sir. Yes.
Dr. P.N. Mahapatra, sir.
Thank you, sir. Thank you very much for your nice presentation. And with that, we are going to welcome our next speaker, Dr. P.N. Mahapatra, sir, who is from Senior Medical Consultant, Director of Medical Oncology from Apollo Multispecialty Hospital, Kolkata. So we are going to invite, sir.
Good evening, sir.
Start.
Okay, sir. Sharing your slide, sir. Sir, is it visible, sir? Right there?
Yeah.
Yes, sir. You can
Thank
start,
you,
sir.
Bayer. Actually, I am in an odd position here, but I will. So, no, I'm in an odd position, but I will try my best. This is about Aranot actually, and again, same darolutamide without chemotherapy. Next slide. This is the disclosure actually for Bayer. I am for this meeting only. I don't have any connections. So, next slide. Actually, long back actually, this is the disclosure. Next slide. Long back actually we had chartered actually, and chartered actually established docetaxel as the standard of therapy in high volume disease. Then Stampede actually had different arms actually. They were arm up docetaxel, arm up abiraterone actually, and if you combine with docetaxel both in high volume, low volume, and abiraterone both in high volume, you will have a better outcome actually. Then came latitude. We actually the criteria of chartered and latitude are different for high volume, low volume actually. And latitude also showed abiraterone, prednisolone. If you combine with ADT, it is better outcome. Then actually Titan came. This is same drug actually, Archis and Enzamet actually. This is enzalutamide and apalutamide. Then actually three drug combination came, RSNs, one of the best trials actually who are docetaxel eligible. If somebody is on a docetaxel ineligible, then Lara not actually. And Peace one actually very little bit trial which is they started with aberrator and then they added docetaxel. This is actually if you add docetaxel, IDT and with a targeted drug, then most likely this Arasense is the best actually. Next slide. Next slide. Next slide. So what are the unmet needs actually? Now what we see in prostate cancer actually, most of the patients are very older actually. They are not very chemotherapy. If you give chemotherapy, they don't want chemotherapy or not eligible for chemotherapy. Having hypertension, lot of comorbidities, taking lot of drugs, and you don't want actually old, frail, don't want to increase the toxicity actually. And those patients actually, if you combine with ADT with some drugs which doesn't have toxicity, that is the best. Next slide. So we know RSNC is better, but it's not possible to give docetaxel to everybody. So R0 was designed. Actually, it was designed to give ADT with actually uh, uh, darolutamide, which is itself has no toxic effect and is a doesn't penetrate to brain much, so doesn't have the toxicity of other drugs like enzalutamide and apalutamide. So these drugs are not trial was designed. Next slide. So this is actually study was actually any prostate cancer. They included patient with PS up to 2. Actually, then they stratified actually as per the whether they have a local therapy given or not and visceral metastasis is present or not. So darolutamide was given in 600 BID dose. So actually, you don't require to dose reduction in this drug. Actually, this is such a nice drug actually. And 2 to 1 randomization. Actually, in prostate cancer, the first thing you will get is a radiological PFS, and the secondary endpoint was OS. And they have a lot of secondary endpoints: time to CRPC, the PSA, time to PSA progression, baseline PSA less than zero point 0.2 nanogram per ml, increase in pain, increase in skeletal events actually, PFS2. So a lot of endpoints were there, and as per the trial, this is an open label trial, and patient go to from the placebo arm, they can go to darolutamide. Next slide. So patient were actually well balanced. They were Asian, white, and blacks actually, and the performance status were morely actually well balanced. 0 was around 50%, and 1 to 2 around 50%, and the PSA more than 8 actually, which are the high risk around 70% actually, and they included. This is one of the trial. They included a lot of de novo metastasis patients, which was actually recurrent metastasis percent was 23% around and de novo around 70% actually. And disease volume, maximum patient were high volume disease, 70% around, and visceral metastasis were there. And actually prostate cancer go more to bone. So visceral metastasis were around 12% actually. And prior local therapy they included, and only 18% patient they had a prior local therapy. Next slide. So it is region wise actually in India is the second recruiter in the Asian region actually after China. So uh, this was during the COVID period they recruited patient, and the 61 patient were recruited from India. So our patient data is good data to be reproduced in the RNO trial. Next slide. So the patient, actually this trial met its secondary endpoint after 2 years actually. Primary endpoint, this is radiological progression-free survival, and it decreased by 46% actually. And you can see the graphs actually, and the decrease is substantial at 46% actually. Next slide. So if you see all the subgroups, if somebody is less aged, more aged actually, if somebody have a PS zero more than one actually, if somebody have a Gleason score less or high, disease volume, high volume, race, any race actually, any geographical area, whether they have a visceral metastasis, non-metastasis, whether they have local therapy. If somebody have a local therapy, they are bad disease, but everybody is benefiting in this darolutamide. Next slide. Good hazard ratio, they're benefiting. Next slide. So OS actually it's immature, and because of crossover actually you will not get OS very soon actually. So OS is immature and not still statistically significant, but other parameters which are more important in prostate cancer trials actually. Time to metastatic CRPC, which is very bad actually. Metastatic CRPC, if somebody do have metastatic CRPC, they die actually. That hazard ratio is 0.40. Time to PSA progression is also same hazard ratio 0.31 actually around. Time to initiation of subsequent systemic therapy also is much better, 0.40 hazard ratio. And time to pain progression, actually a lot of the prostate cancer problem is pain actually. And if you see other trials, they didn't included the pain actually, and pain was one of the criteria in this trial actually, and the hazard ratio is good, 0.7 around. And next slide. So you can see the time to metastatic CRPC, the in prostate cancer CRPC is the most bad thing actually. The graphs are separating and the good hazard ratio, and the pain progression also. During the time actually pain progression is very less, so the patient are pain free and better quality of life. Next slide. So if you see the actually there is a PSA, we give a lot of varieties, and we see somebody with a PSA which is 0.2 nanogram per ml. Actually, that is the standard PSA. If somebody have this PSA response, the response will be better and prolonged actually, and more patient than the Darutmad arm, around 63% patient have less than 0.2 nanogram per ml. Actually, it is more than 69% versus placebo. So the response to PSA and the time to PSA progression, and somebody having undetectable PSA that is less than 0.2 nanogram per ml is much more in darolutamide arm than placebo. Next slide. So we had in both high volume and low volume disease actually, more patient had a PSA which is less than 0.2 nanogram. Actually, you see in high volume disease, they are bad actually, but if you compare with both high volume and low volume, equally patient had a good PSA response, which is undetectable PSA or 0.2 nanogram per ml in the darolutamide arm than the placebo arm. Next slide. So actually, more patient. This is a crossover trial. More patient actually had in placebo arm subsequent therapy than the darolutamide arm, but the maximum patient had docetaxel chemotherapy. Actually, other treatments are given. Actually, we know after this actually placebo and darolutamide will be effective, but after darolutamide they may not be very effective actually. But so XM patient actually gone to docetaxel arm. Next slide. So the side effect actually, darolutamide is such a nice drug, doesn't increase the side effect more and above the anti-androgen therapy. You can see there is no side effect which is more than the placebo arm. So the side effects are equal actually. Somehow in this trial, the fatigues were less in darolutamide arm than the anti-androgen arms. Next slide. So these are the typical side effects actually of the anti-androgen treatments actually. Darolutamide is not increasing any side effects more and above the which is ADT. Next slide. This is the side effect actually. But I personally don't think the darolutamide doesn't increase and they don't have the much drug to drug interaction. So side effect profile is extremely good in this drug actually. Next slide. So now actually quality of life is very important. So you have a FACT score actually. FACT score is actually doesn't manage the prostate cancer score plus the emotional social well-being actually. There is fact different fact head and neck fact prostate score actually. So they scored at the fact points actually, and in the fact score actually, there are two might scores above the placebo. Next slide. So if you see the PET score actually, that is not only drug related score or patient cancer related score, that is physical well-being, social well-being, emotional well-being. That is very important actually, functional well-being. And if you see the main problems of prostate cancer is bowel and urinary symptoms actually, that are much better in darolutamide than the ADT arm actually. Next slide. So I'll conclude actually darolutamide and ADT actually because our patient actually not much patient, many patient will not be eligible for docetaxel. If somebody is eligible, think docetaxel darolutamide with ADT is the best. But if somebody is not eligible or not want chemotherapy, then darolutamide ADT is one of the best. Actually, they all this course actually the OS actually is not mature, but this type of trials will see even a OS actually very late you will see, and other parameters, pain, PET scores, PSA, undetectable level, time to CRPC, all are much better. If you combine that with the ADT, then only ADT. Next slide. Thank you.
Thank you, sir. Thank you. Thank you for your nice presentation, sir. And thanks for your valuable presence due to your busy schedule and fact and other programs also. Thank you, sir. And just
Thank
wait
you.
a minute. And if someone have any questions, or otherwise we are going to conclude the session, sir. I think, sir, there is no any question from audience, so we can go for to conclude the session.
Thank you.
Thank you,
Thank
sir.
you.
Thank you so much.
Thank you, sir. Thank you, both Devapriyo sir and Mahapatro sir also. Thank you very much.
Good night. Good.
Good night, sir.
Good night, sir.
Yeah, Tech team, you can go out. I think it's all over.
Can we close the session?
Yeah, you can conclude the session.